All right, class. So this video will give you all an overview of what Medicaid is all about, even though I know we've just covered it. And after watching this video, we will be discussing the differences between Medicare and Medicaid.
Medicaid is a U.S. healthcare program that finances the care of low-income and certain high-risk populations, including low-income children and families, people with developmental or physical disabilities, low-income nursing home residents, and others. Unlike Medicare, which is a federally funded and administered health insurance program available to everyone over 65, regardless of income, Medicaid is a need-based program funded jointly by the federal and state governments and administered at the state level. In 2009, Medicaid financed the care for nearly 20% of all Americans, making it the largest source of medical coverage for the country's low-income population. In the coming years, under the Patient Protection and Affordable Care Act, Medicaid will expand to cover a much larger proportion of the population in certain states. And yet, despite the growing importance of Medicaid, most Americans do not understand how it is funded. Medicaid begins with a mix of federal and state funding. The federal government makes annual Medicaid payments to states based on their federal medical assistance percentages, or FMAPs. Each state's FMAP, which is determined by a formula that looks at state per capita income relative to the U.S. average, is set somewhere between 50 and 83%. This means the federal government pays between 50 and 83 cents of every Medicaid dollar, leaving the state to pay the difference. While the proportion of federal and state dollars is set each year, the total amount is unlimited unless the state and federal government have agreed to special financing terms under a waiver of the Medicaid rules. These funds can be further supplemented through a number of different federal grants. A state may use alternative sources of income, such as tobacco or provider taxes, to fund its Medicaid program. This accumulated pool of healthcare money helps to fund the populations in a given state. If people have other sources of healthcare funding, such as Medicare or employer-sponsored insurance, those parties may have to provide funding before Medicaid, since Medicaid is a payer of last resort. While the federal government has mandated legal minimums for Medicaid, including minimum access to care, eligibility requirements, and medical service requirements, there remains great flexibility from one state to another in how programs are administered. One of the ways states utilize this flexibility is through waivers, which allow for expanded services and enrollment, and in some cases allow innovative solutions. Each state establishes the reimbursement rate that will be paid to hospitals, physicians, pharmacies, and other healthcare providers. Medicaid reimbursement rates are typically lower than those paid by Medicare and commercial health insurance carriers. While most Medicaid payments are made to providers based on the services performed, other financing components sometimes complicate the picture. These may include special payments to providers that provide care to a high number of low-income populations, rebates paid from the pharmaceutical companies to state and federal government, or clawback payments made by the states to the federal government to offset the cost of prescription drug coverage offered under Medicare Part D. Adding another layer of complexity, the Patient Protection and Affordable Care Act will expand Medicaid to a larger percentage of those who are currently uninsured, as well as to other low-income individuals. The Medicaid expansion population will be paid at 100% by the federal government for calendar years 2014 through 2016. However, this federal contribution decreases over time, with the federal government paying 90% and the states paying 10%, beginning in calendar year 2020. In addition to expanding Medicaid coverage to new populations, new financial requirements for both state and federal governments will add to an already complex system that is projected to grow to more than $900 billion by 2020. To learn more about Medicaid and other important healthcare topics, visit milliman.com/HCR.
All right, now that you've watched the video, I will be covering the difference between Medicare and Medicaid very briefly. Medicare is a federal program that provides health coverage if you are 65 or older or have a severe disability, no matter your income. It's an entitlement program. And also, Medicare beneficiary with low income may receive help from Medicaid, which will pay for premiums and deductibles. Now, with Medicaid, it's state and federal. It's a state and federal welfare program to assist indigent with their medical needs. Dental care is limited. Medicaid beneficiaries cannot enforce their rights for eligibility in comparison with Medicare, who they can enforce their rights for eligibility in the federal court. Also, Medicaid may pay premiums, again, of Part A and Part B for those that qualify, who are Medicare beneficiaries, which I just touched on as well. Now, we will be discussing CHIP, which is the Children's Health Insurance Program, Title 21 of the Social Security Act. All right, so this act was enacted under the Balanced Budget Act of 1997, but it's a state-based program. It covers children up to the age of 19 from low-income families who are not covered under a private plan. States have generally established 200% of the federal poverty level for eligibility, but some states have higher limits. The Affordable Care Act authorizes CHIP through September 2015, but requires current eligibility standards so it can remain in place through 2019. All right, so now I am going to jump to the Military Health Service. We will be discussing TRICARE. So there is a video that also explains the Military Health Service. It's in the previous slide. And I will be discussing TRICARE. So the healthcare program for military personnel, their dependents, survivors, and retirees is operated by the Department of Defense. Each of the military departments, being Army, Navy, and Air Force, operates its own medical facilities. TRICARE is the insurance arm of military healthcare. Active duty personnel are automatically enrolled at no cost in TRICARE Prime, which is a comprehensive managed care plan. Let me jump to the next slide really quick. Now, active duty personnel, again, are automatically enrolled, and dependents and retirees also have other TRICARE options. So another option is the VHA, which is the Veterans Health Administration, and it's the health services branch of the Veterans Administration. It operates the largest integrated healthcare system in the U.S. with more than 1,400 sites throughout the nation. Both service-related and non-service-related conditions are treated on a priority basis. Veterans with service-connected illnesses and disabilities, low incomes, or special healthcare needs receive top priority. More than half of the veterans served by VHA have no service-connected disabilities. Funding for the VHA program is appropriated in the annual presidential budget approved by the Congress. The structure of VHA funding is patterned after the global budget model, in which the budget appropriations are determined in advance for the entire system. The VHA then distributes the funds to its organizational units, having oversight for the delivery of health care. The VHA also operates the civilian health and medical program of the Department of Veterans Affairs. Okay, so the civilian health and medical program of the Department of Veterans Affairs, talk about a mouthful, covers dependents of permanently and totally disabled veterans. So the VHA shares the cost of covered healthcare services and supplies with eligible beneficiaries. Now I'm going to jump to the slide covering the topic of Indian Health Service. There's also a video that I won't be showing in the lecture, but you can just click your control and click on the link and you will be taken to YouTube to watch the history of the Indian Health Service. All right, so here is the link and then a little about the Indian Health Service. So it's a federal program. It provides comprehensive care to Native Americans living on reservations and in rural areas. Now, the IHS operates its own hospitals, health centers, and health stations, and some services are contracted from private providers. So it serves about 1.9 million American Indians and Alaska Natives residing on or near reservations, and services include health promotion and disease prevention, as well as programs in substance abuse, maternal health, child health, sanitation, and nutrition. Now, the last topic I'll be covering, since this video or this lecture has gotten pretty long, is the topic of reimbursement. All right, so there are numerous reimbursement methods that exist and that are used for different types of services. So the first one we have listed is fee-for-service. Charges, or in other words, prices, are established by providers. Each service is separately billed. There is an incentive to provide non-essential care. Now, the second one listed is bundled charges or payment package pricing. Bundled payments. And what this is package pricing reduces provider-induced demand because the fee is inclusive of all bundled services. So healthcare spending is reduced without affecting the quality. So package pricing. Now the next one, which is RVS, which is the acronym for Resource-Based Relative Value Scale. So a relative value is assigned to each current procedural terminology coded physician service. Now there's something called RVUs that are relative value units that are based on time scale and intensity that it takes to provide the service. So this is really assessing the physician's work. Now separate relative value units are assigned for overhead costs and malpractice insurance. Relative value units for each service is adjusted to reflect geographical cost variations. So this uses the Geographical Practice Cost Index. Each year, Medicare establishes a dollar conversion factor and reimbursement for a service equals relative value units times that dollar conversion factor that is established by Medicare. Now, there are slides for each of the components that are listed, the different types of reimbursement, but I'm going through them now, and you can, of course, use your slides and go through as I am covering them. So managed care approaches, we have preferred provider approach, which has a discounted fee schedule, and it's fee-for-service charges that are discounted. Now, the next management care approach is capitation. The provider is paid a set monthly fee per enrollee, referred to as a per member per month rate. So the fixed monthly fee is paid to the provider regardless of how often the enrollees receive medical services from the provider. Now, the next component is cost plus reimbursement or retrospective reimbursement. So when we're talking about retrospective reimbursement, we're talking about a reimbursement methodology that sets rates after evaluating the costs retrospectively. So when we're talking about cost plus reimbursement, we're talking about the per diem rate based on historical costs. Then we have prospective reimbursement, which uses certain established criteria to determine the amount of reimbursement in advance. So the idea is we're looking forward. So it's based on pre-established criteria. Rate is established in advance of the delivery of services, and that covers it for the different reimbursement methods. I will be jumping back to the information from the chapter section in this week's module, and make sure to read the chapter and go through all the slides. They're pretty self-explanatory. All right, so I'm back here. Make sure to go through these diagrams, the information here, which we pretty much went over. All right, so before I end this video, I just want to point out that everything towards the end of this page is from chapter 9, which there's another lecture that goes with that chapter. So this specific video goes along with the other videos that go along with chapter 6. All right, so that wraps it up. If you have any questions at all, do not hesitate to let me know. Take care. Bye.